Hey there, going live today to talk about hypermobility and functional neurologic disorders. What's the connection? And we're going to talk about a hot off the press article that was just published this last month in February of 2024. So I'm excited to dive into this topic because this is something that we see clinically a lot at re+active, which, by the way, if we haven't met, my name is Julie Hirschberg. I am a neurologic physical therapist and the owner and founder of re+active. I got my original logo shirt on. This is from 12 years ago. But we're in the Los Angeles area, and I have a team of physical therapists, occupational therapists, psychologists, yoga therapy, personal trainers, all working with people with neurologic disorders and people with EDS, hypermobility spectrum disorders, people with dysautonomia like PODS, and we see a lot of overlap of many of these disorders. Somebody said here, great topic. I'm glad you're here. It is a great topic. It's something I care very deeply about. So let's dive in. By the way, if you're on our newsletter, I'll send a link to this article. It is free full text, so you can download it. There's some really great figures in this article that I highly recommend. And if you're not on our newsletter, you can go join it as a patient at reactivept.com or as a clinician at reactiveeducation.com. And the paper is in Brain and Behavior, and it is called Functional Neurological Signs in Hypermobile Ehlers-Danlos Syndrome, or EDS, and Hypermobile Spectrum Disorders with Suspected Neuropathic Pain. The group that published this is out of Switzerland, and again, it was from the February 2024 is when it was published, so just recently. And I thought it was really interesting how the authors talked about how they started looking at this, because I think it's such a clinical thing where we start seeing combinations of things. And so I'll tell you, my interest in this comes from, we've been working with people with FND for the last 12 years or so. And we noticed that a lot of those folks also had hypermobility, maybe undiagnosed hypermobile EDS or a hypermobile spectrum disorder. Sometimes it was diagnosed, but sometimes not. And we were screening it and finding it and realizing folks really needed to address the underlying issues that come with that, which include joint stability, but also proprioception and sensory issues that come with hypermobile joints. So we've been seeing this clinically, and it has just started to be in the literature. So this is not the first article. In fact, I brought up another article up here. This was from 2022 from a group in Spain who first published some of the first findings of hypermobile spectrum symptoms in patients with FND and autism. So many links and connections here. Somebody is asking, what are the main symptoms of hypermobility? Great question. And somebody else asked me this ahead of our live too. So I wanted to point people to a great resource, which is the Ehlers-Danlos Society. This is a wonderful nonprofit group. Our team specifically has done a lot of training and learning with them. They have this really great EDS echo group that our team has done. I've done some other trainings with them, but a wonderful group. So I'm going to point you to that. They have both EDS, so Ehlers-Danlos syndrome, and hypermobility spectrum disorders. And they talk about what does this mean and what are the diagnostic criteria. And one of the main things is when a person has hypermobility, they have extra motion in their joints, and particularly in being diagnosed with this, they have symptomatic joint subluxations, more typically in the shoulders and ankles, but the joint will sublux, might I'm doing this with my shoulder because this is like an anterior joint subluxation would be common in the shoulder where it might move forward out of the joint, and it's painful, very painful. And so symptomatic joint subluxation is part of the diagnostic criteria, because somebody else asked, is hypermobility a diagnosis or a symptom? That's such a good question because it is a symptom. The hypermobility spectrum disorder or hypermobile EDS would be the diagnosis. The hypermobility is the symptom. And people could have hypermobility without the diagnosis. And a lot of these are genetic disorders as well. So there's genetic tests, and I think it's like 90% of folks with hypermobile type EDS actually have some positive genetic findings, but not everybody. So again, I'm going to refer you to the EDS Society because they are fantastic, and we personally have done a lot of learning with them and have actually applied to be a center of excellence because our team is really, really passionate about this disorder. So I'm going to go back. Let's talk about this article. So again, it was called Functional Neurologic Signs in Hypermobile EDS and Hypermobile Spectrum Disorders. And this is what the authors talk about in the introduction to this. So this was a group that's already working and researching and studying people with hypermobile EDS and hypermobile spectrum disorders. And they were studying folks that had chronic pain and finding things like small fiber neuropathies in some of these folks. And as they were studying and looking at the presence of small fiber neuropathy, they would do sensory assessments. So this is really common. A neurologist or a therapist would do a sensory assessment. And they found really unusual sensory findings. In fact, they found a lot of functional sensory findings, things that did not match the neuropathy that the person had. And what they suspected is that there might be a coexistence of a functional sensory disorder or functional neurologic disorder with sensory signs to coexist with the hypermobility disorder. Not sure which would come first. They have some thoughts. I have some thoughts about it, particularly because a person with hypermobility might not be getting great sensory feedback or input to the brain, and that could lead to or cause some of the functional sensory symptoms. So this group, because they saw this when they were testing with neuropathy, they said, let's look at a group of people that have had sensory and motor testing done, and do they have the characteristics of a functional neurologic disorder. They did not diagnose them. These people were not diagnosed, so they were really looking at what are some of the positive clinical signs and symptoms of FND in this group of people that had already been studying. So I want to give you some of the data. I believe it was 24 people total. I'm just looking for that. These were people who were diagnosed according to the 2017 criteria. They were diagnosed by a rheumatologist, so that's usually the person that would diagnose this. And they were referred to their center for pain. So I think this is another key component of this study, is that these folks have pain. Personally, I don't think I've met a person with hypermobile EDS or hypermobile spectrum disorder that didn't have pain. But then again, they come to me as a physical therapist because of pain. So that makes sense. So they then looked at, in this group, did they have positive clinical findings of functional neurologic sensory symptoms? So they're, or and or both, did they have signs of functional motor symptoms? So functional motor symptoms that they looked at were sternocleidomastoid weakness, unilateral, which would not occur because of the way the sternocleidomastoid is innervated. The Hoover sign, which we've talked about before. And they had one other, drift without pronation. This is an interesting test because in neuroanatomy, we teach a clinical sign of the pronator drift test. This is a sign of upper motor neuron weakness. So a person is put their arms out, they close their eyes. What we typically see in neurologic weakness is a drift of the arm and start to pronate. Drift without pronation is a sensitive and specific sign for upper extremity functional weakness. Very interesting. If you didn't know that, now you know. So they looked at those 3 motor signs, and then they looked at positive sensory signs for a functional neurologic disorder. One of these being they did vibration at the sternum, and was there a split side to side? Because again, anatomically, the sternum as a bone would not split vibratory sense. Same with the temporal bone, so that would be an unusual sensory finding, a functional sensory finding. And then they did a test that I had never heard of, and it's called the Bolus Courier test. And in fact, I had to look up this test. So what they do is actually have a person cross their hands, and then they do the sensory testing to see if it matches the sensory testing without it. I find this really interesting because that certainly throws your brain for a loop, and it's almost like a sensory perception test at that point. So a positive sign on that would be a functional sensory symptom. And then finally, they just did sensory testing, just like we all do all of the time, where we're testing for a particular pattern of dermatomal loss or peripheral nerve pattern of loss, and found a sensory loss that did not match those anatomically. That also would be a functional sensory sign. By the way, those are great tests for you to look at if you're screening for the presence or wondering, is this actually a functional sensory disorder? And yes, a person could have a neuropathy or small fiber neuropathy and a functional sensory disorder. So those were the tests. Very interesting. Okay, so let me talk about the sample. So it was 24 people, 14 with hypermobile EDS and 10 with hypermobile spectrum disorder. They ranged from 21 to 54 years old, and they all had chronic pain that was interfering with their daily life. So this is what is very interesting. 22 of those 24 people had at least one positive test. Now, one positive test doesn't mean a person has a functional neurologic disorder, but it does mean they have a functional neurologic sign. So 5 of those, so 20% just had one, 14 had 2 to 4 positive tests, and 3 people had 5 or more. And right now, our diagnostic criteria for FND is not like you have 1 or you have 2 or you have 5. It's a constellation of symptoms. Again, the purpose of this was not to try to diagnose people with FND, but to retrospectively go through and look at how many of these folks with a hypermobility disorder had functional signs. What is really interesting is that none of the patients had just isolated motor signs. They did have isolated sensory signs, but not isolated motor signs. And I thought that was really interesting and honestly makes more sense to me because of the sensory changes that occur in for a person with hypermobility, because they are not always getting accurate information from their joint receptors because of the hypermobility. So they also, by the way, compared these to healthy controls without hypermobility. And those folks had, I think, 2 people who had functional neurologic signs. So so that also was really interesting. And I'm glad that they compared to a control group. So what was the overall? So overall, 22 out of 24, so that's 92% of the sample, which is not a very big sample, right? So this does not encompass all types of people. 92% of this sample of people with hypermobile EDS or hypomobile spectrum disorder and pain also had some functional neurologic signs. They were not diagnosed with FND, but they had signs of that. And more sensory signs than motor signs. What do we do with this information? I'm gonna give you my thoughts about this. And I'm just looking at this person's comment. After my perfect storm, hospitals say my FND started when these episodes hit me in presence with very painful, forced, hypermobile contortions. Well, I think that makes a lot of sense. So I have talked a lot about how our sensory system greatly influences our motor output. And particularly when it comes to the brain and how the brain organizes movement, organizes our control of movement, our voluntary movement, it works in a predictive fashion. So our brain, to be efficient, predicts our movement patterns and creates them before we even get input, and definitely before we get any sensory feedback. So our brain predicts, it's a predictive machine, a very creative machine, but it predicts these things. Part of that prediction process is to get feedback to say, yeah, that prediction was right, or no, that wasn't quite right. We need to change it up. In a person with hypermobile EDS or any type of hypermobility, they may not, potentially, it's not all people, may not be getting accurate feedback particularly from their joints, but also from skin stretch. So a lot of folks with hypermobility syndromes will also have really like soft, stretchy, velvety skin. So both skin stretch and the joint proprioception provide feedback to the brain about, was that movement accurate? Did we do that right? And for the person with hypermobility, they might not be getting that accurate information back to the brain, which could then develop into a faulty pattern of movement. And that's how the brain works. It's just not getting great feedback. Now, the good news is we can improve that feedback, whether that's through supporting the joints, through compression or bracing, vibration, extrasensory input, actually training the sensory system a little bit better, and not take away that person's hypermobility, but just give them extra sensory resources so the brain is getting more accurate feedback, and we can reverse some of those pieces. Now, I find the sensory symptoms that they describe in here very interesting because they can come right alongside a neuropathy. And this we see as well. So particularly in a small fiber neuropathy, but really in any kind of neuropathy, when a person has a neuropathy, they also are perhaps not getting accurate sensory feedback to the brain. And that can then lead to the development of a pattern of movement, a pattern of muscle contraction, tremors, abnormal movements, even dystonia. that is functional because the brain is reacting and responding to the sensory input that's coming in. So again, big take-home point for us as clinicians is that number one, we need to screen for the presence of hypermobility in the people that we see with functional neurologic disorders. Number two, when we're working with folks with hypermobility and they're having symptoms that sound like FND, we should screen for those. And we have very good positive clinical tests like the Hoover sign, like the sternocleidomastoid, like drift without pronation. All of those pieces we should test and screen. As a clinician, we don't, as a physical therapist, I don't give a diagnosis. I never tell somebody, well, here's your diagnosis. That is for a neurologist. But if I'm seeing these things and I'm screening, because we should absolutely be screening these, if we're screening these, then we would refer them to a neurologist. So somebody asked me before our live, what should we do if we start to suspect these or we see this in a person that we're working with who has hypermobility? We refer them to neurology. We do the testing, we provide them with findings, and we refer them to neurology. And I would write up a very thorough report of positive findings. And I wouldn't just rely on one finding. Just like if I'm testing for reflex activity, I don't do one reflex. And I don't just do the Babinski sign. I do multiple, and I bring all of that evidence to a physician to say, hey, I'm working with this person for this, but I'm seeing this. Now, regardless, and this is what they talk about in this article, if you're screening this, you're referring to neurology, great, but you're still working with the person, you're still treating things, you're working together. You consider and should consider addressing the functional neurologic disorder alongside the other things that are occurring, whether that is EDS or that is POTS or that is a sprained ankle, like whatever those pieces are, you're going to treat the whole person and treat them together. And here's what they say. In fact, I think this is the last line of the article. They say, FND can severely interfere with rehabilitation efforts in any population, right? So they were studying in the population of people with hypermobile EDS and hypermobility spectrum disorders. And FND targeted physical therapy. They ended PT, but I'm going to go PT, OT, speech therapy, psychology should be combined. Actually, they say perhaps, I'm going to just say should be combined with the approaches for people with hypermobility. We cannot separate these things. They should be combined. We should be treating someone as a whole person. They also said that this deserves more study, right? So this was really a pilot study. It was only 24 people. But we should be screening for this. Now, I'm not screening every person that we see with a hypermobility spectrum disorder or EDS. I'm not screening every person for functional neurologic disorder. But if they're coming and they're explaining signs and symptoms that are very consistent with FND, then I'm going to do these screens. I'm going to screen for the presence of functional sensory signs and functional motor signs. And I highly recommend this article. I'm going to put it in our newsletter this week. And it includes a really detailed summary of all of the tests, including pictures of how to do them. I love when studies do this because it's so helpful. So go get on our newsletter if you're not already. As a patient, sign up at reactivept.com. As a clinician, sign up at Reactive Education. I'll send out this study. I'll send out this video. And it's really a wealth of information every single week. Now I'm going to get back to a question. Yeah, this person is saying my limbs go numb, and then they move on their own and go into contortion. So that, yes, that is what can happen when the limbs go numb. If you're not getting good sensory information from your limbs to your brain, then the brain's going to have a real hard time interpreting where you are in space and can cause really unusual movements. So probably this makes sense to you then, that this could occur. So there you have it. Again, the article was in Brain and Behavior just last month. It was called Functional Neurological Signs in Hypermobile EDS and Hypermobile Spectrum Disorders with Suspected Neuropathic Pain. First author is Fernandez, and it's out of a group in Switzerland. I will put the link in our newsletter this week. And yes, so I can link that, and I'll put a link in our story today too. And just want to thank you. Thank you for great questions that spur me on to read more and to learn more and to just keep getting curious, so that we can help people get better faster. Right? So here's the thing. If you have a person with a functional neurologic disorder and you haven't screened for the presence of hypermobility, you're missing something. You're missing a big thing that can really help that person get better so much faster. Likewise, if you're working with somebody with hypermobility that is reporting symptoms that are like FND and you don't screen for FND, you are also slowing down their progress to recovery. So screen it, assess it, refer, treat it. Both are things that can be supported and treated. We don't take away somebody's genetic disorder of hypermobility. We don't. But we can absolutely help a person manage it, and people can live very full lives in the presence of it. So thank you so much for joining me live, and keep the questions coming. I love to hear from you, and we'll see you again soon.